So good morning, good afternoon or good evening, depending on what time of day you are watching this. And a very warm welcome to the Kent Surrey Sussex Academic Health Science Network session for our Respiratory Collaborative. And it is with great pleasure that I can say that I have with me today on Zoom Professor Singh, who is Professor and Lead for Pulmonary and Cardiac Rehabilitation at Glenfield Hospital in Leicester. Now, I know most of you will need absolutely no introduction to Sally, but she has a formidable CV, and I think it is just worth outlining some of her very important roles and functions at the moment. I guess, to put it bluntly, she's kind of leading pulmonary rehab in this country and integral to leading it internationally. So she is currently the clinical lead for NHS England's respiratory workstream on pulmonary rehabilitation. She's the clinical lead for the National Asthma and COPD, that's the NACAP audit and the pulmonary rehab arm, and the clinical lead for the Pulmonary Rehabilitation Accreditation Scheme, PRSAS. She co-chaired and still does the British Thoracic Society Guideline Group on evidence-based guidelines for pulmonary rehabilitation and co-chaired the ERS ATS Pulmonary Rehabilitation Guidelines. She is the incoming chair of the American Thoracic Society Pulmonary Rehab Assembly, and many, many other roles, too numerous to mention. So without further ado, Sally, Guru Extraordinaire of PR, a great warm welcome to you.
Thanks, Julia. Pleasure to be here.
Lovely to have you. And today's session is obviously about pulmonary rehab. It would be a bit mean to ask you to talk about anything else, really. And what we've asked you to cover is two key topics for all our clinicians and providers, and that is what is happening to post-COVID rehabilitation for the patients who've had COVID, and also for those returning to face-to-face rehab for our conventional chronic lung disease patients. So do you want to tell us how you're going to start and what you'd like to do?
Well, I think we've obviously had a little bit of a chat about how we're best going to do this. And I think there are two key issues that people are interested in. One is the recovery piece around COVID. And as importantly is really maintaining services for people with chronic lung disease that had access to pulmonary rehab, but of course during lockdown, were denied access, like many other services. We all closed down. So it's talking about how we open up and how we meet some of the challenges that are now upon us. So I thought we'd talk about the post-COVID rehab and then reopening the pulmonary rehab program. And I've got a set of slides around that to hopefully help the discussion along. So I thought what I'd cover was this idea of recovery and rehab and sort of create this case of need, and then look at the potential rehabilitation pathways around COVID, and then look at the reopening for business as usual, but I think we'll have a break before we get onto that section. So this slide is probably very familiar to most of you, that catalogues the symptoms that patients face with during an acute admission and then in the post-COVID follow-up. And for those of us that are involved in rehabilitation, clearly we're more interested in the right-hand side of this graph. And you can see that the top symptoms are fatigue, breathlessness, joint pain, and some chest pain. And whilst those of us that are in rehabilitation are familiar with some of them, you might argue that particularly around joint pain and chest pain, they're not symptoms that we commonly manage within the context of a pulmonary rehabilitation program, although of course cardiac rehabilitation is very familiar with chest pain. The following symptoms as you go down are really a very mixed bag of symptoms. From a rehab point of view, I think we're very familiar with exercise capacity and measuring exercise capacity. And this is data taken from a systematic review published earlier this year, looking at the impact of other respiratory pandemics, notably SARS and MERS. And I think there's two striking things about this table without taking you through all of it. The first is the average age of the population that were followed up. So this is a group of people that were followed up to 12 months post-admission. And you can see that actually they're much younger than we would normally see in our rehabilitation programs, either pulmonary or cardiac. And the mean age ranges from late 30s to early 50s. On the right-hand side, we have a measure of exercise capacity, and this is the 6-minute walking test, which many centres use as an outcome measure in pulmonary rehabilitation. Now, for those of you that aren't familiar with this as a measure, you'd think, well, that seems quite a large number, doing 500 metres in 6 minutes. But actually, if we were looking at age-matched controls, we would expect them to be doing 700 or 800 metres. So you can see that this previously fit and well group, even up to 12 months post-discharge, are really struggling in terms of regaining their exercise capacity to quite a significant degree. This systematic review also looked at other symptoms that have been certainly talked about in terms of COVID and catalogued them post-MERS and SARS. And here we have a graph of PTSD, anxiety, depression, fatigue, and pain. And not all studies measured all of those, but you can see there are really strikingly high levels of anxiety, PTSD, fatigue, and pain in this, again, young population up to 12 months post-discharge. So there really are some traits that are being observed that would be very amenable to a rehabilitation type intervention. Now, pulmonary rehabilitation has been suggested to be that ideal repository for patients with post-COVID syndrome, but you might imagine that the rehabilitation programme would need adapting to accommodate this really wide range of symptoms that patients are exhibiting. And many of you may have read this article in the BMJ looking at patients that are predominantly managed in the community, but that seems to coalesce around this idea that pulmonary rehabilitation may be a good intervention for these people. And you can see that identified with the arrow on the bottom left-hand side. I'm not going to take you through all of this diagram, but actually it's an interesting diagram and takes us through some of the challenges of managing the post-COVID patients. This is particularly referencing community managed patients. So for those of you that aren't familiar with a definition of rehabilitation, I'll just take you through it. And this is the definition from the British Thoracic Society. And it identifies pulmonary rehabilitation as this interdisciplinary package of care for patients with chronic respiratory disease. And importantly, it's individually tailored so that it maximises each individual's physical and social well-being and level of independence. And importantly, programmes are uniquely identified by their ability to individually prescribe an exercise programme and have this education package that really do support an individual's self-management. So in terms of how we might adapt the rehabilitation programme for the post-COVID patient, there has been some guidance. This is an article that was a consensus piece developed by the European Respiratory Society and the American Thoracic Society. And there were a number of questions that went out for review by experts to try and gain some consensus around this. And I've just highlighted some of the questions that were brought to the table and the results. Very generally, there was overwhelming support for a rehabilitation package in this population that should start certainly in hospital, but I think many of us that are involved in rehabilitation are very much more familiar with this structured discharge package. So I've just pulled together a couple of the key questions that identified aspects of this predefined package. But you can see on the top left-hand corner that clearly there was enthusiasm and consensus around people being encouraged to be active upon discharge, and that at around 6 to 8 weeks post-discharge, of course that would be ideal, patients should have a formal assessment of their physical and emotional functioning to try and identify what their unmet rehabilitation needs may be. And then perhaps not surprisingly, there was clear consensus on offering a package of care that would certainly mirror a rehabilitation programme, but arguably more comprehensive, and that would certainly be advantageous compared to no rehabilitation programme at all. A second piece of work, which to a certain degree complements that, and indeed some of you may have taken part in, was a survey that was supported by the British Thoracic Society that looked at the essential components of the assessment for these patients with COVID, and also the assessment, components of the programme. Now, this just identifies what that there was agreement on around the assessment at 6 to 8 weeks post-discharge. Now, not surprisingly, there was strong agreement around all of the aspects that we would conventionally assess within the context of pulmonary rehabilitation, for example, cough, breathlessness, lung function, quality of life. But I think there were some aspects that those of us in rehab don't directly and commonly manage or certainly assess, and that would be things like fatigue and PTSD. So I think there are some subtleties around patients with COVID that we need to broaden the complexity of the assessments prior to any recovery programme if we're going to address patients' needs. And this is the pathway that was developed on the back of this survey that is now a paper that's being submitted for publication and has been reviewed and has now gone back with corrections. So we're hoping it's going to be published shortly, but there's never any guarantees in this world around publications. I think what's important around this is that there's 2 routes into the rehabilitation programme. So you can see at the top of the diagram, patients that have been discharged may be picked up by a COVID recovery team. They may have a telephone call, and that's certainly standard practice within cardiac rehabilitation, where patients at discharge are routinely followed up. But importantly, at the point of discharge, there may need to be special services offered by dietitians, physiotherapists, etc., and perhaps importantly, psychological services in terms of accessing IAP services. The suggestion is then that the patient should come for this comprehensive assessment, but you can see at that point there is the possibility for patients to be referred in from primary care. Now, clearly that does bring some challenges if we're going to consider patients that have not been admitted to hospital and therefore may not have a confirmed diagnosis of COVID. However, assuming there is a screening process and they are safe to be referred into a rehabilitation programme, arguably there's no reason why these patients shouldn't be accepted. At this point, the assessment should be more comprehensive than currently conventional pulmonary rehabilitation programmes are. Certainly there's an enormous amount of overlap, but I think there are things that need to be added into the assessment for the post-COVID patients. Equally, I think that the package needs to be offered with much more integration with specialist teams. And again, I've listed them here: speech and language therapists, physios, dietitians, OTs, etc. And of course, in an ideal world, we'd have an option for delivering packages of care to these people. So that some patients may choose home-based, centre-based, a digital option, which I'll come on to in a moment, and or community programmes. And of course, that should be wrapped by a discharge assessment so we can begin to understand the impact of these interventions for these populations. So in terms of delivering centre-based rehabilitation, the British Thoracic Society have published some guidance around that, with particular attention to some of the red flags in patients with COVID, particularly around their cardiac status and significant breathlessness. So we do need to be more mindful of that than perhaps we might be in the conventional COPD population. The ATS have produced guidance on opening pulmonary rehabilitation programmes for business as usual. I just thought this was a nice infographic to help us think about the things that we need to consider, both for the business as usual and the post-COVID population. So in terms of delivering a service, the practical issues around infection control, social distancing, are no different for the post-COVID population than they might be for a conventional group of people that have got the sort of the more routine entry requirements into pulmonary rehab. So in terms of the digital interventions for COVID, some of you may be aware that NHSE have supported the development of a COVID recovery website. This site is divided into 2 phases. Phase 1 is accessible now, and you can see the landing page. And it's really very high level, light touch information for patients and their carers that have had COVID to help them understand the symptoms, begin to realise that what they're experiencing, whilst uncomfortable, isn't abnormal at this stage, and to help people do the right thing in terms of really achieving a full recovery. The beauty of this site is that it received contributions in a really collaborative way from many other societies that would have a vested interest in supporting the management of those with COVID. So the group comprised the Chartered Society of Physio, the College of Occupational Therapists, the British Society of Rehabilitation Medicine, British Dietetic Association, the Speech and Language Therapy Society, British Psychological Society, and the list goes on. So we've been very privileged to have such a wide range of people that are very keen and happy to contribute. And perhaps most importantly, we've developed this with patients that have had COVID. So everything that is on the site has been developed collaboratively with the patient, and they have reviewed every word that is on the site and given us suggestions around how to improve that.
Thank you very much, Sally. Very interesting data, and obviously a very complex situation and a complex group of patients. And it's interesting that you talked about how you might treat them the same as patients with chronic lung disease, which was going to be one of my questions. Is firstly, do you in your service exercise the post-COVID patients in the same class as your chronic lung disease patients? I suspect I know the answer, but it'd be interesting to hear.
No, we don't. We have discrete classes for our normal COPD patients and other chronic respiratory diseases, and the COVID patients are quite separate. I mean, in terms of practical procedures, it's remarkably similar, but the content is subtly different in terms of the educational component particularly. Mm-hmm. And interestingly, I think they're a much younger group, even though these are people that we've seen that have been hospitalised. They do tend to be younger than our conventional
yeah. And of course they're the survivors, so it's good that we've got younger patients in that client group.
Yeah. And it's interesting that that some of them come with comorbidities, but not all of them. So it's a really mixed bag. It's quite striking how the psychological impact of the disease is really quite profound in some, not in others, but it is in some.
And that's a very interesting point, and perhaps one we haven't got time to discuss, but just floating that, I think also probably a lot of us would think that the psychological stress of chronic lung disease is underestimated and undermanaged. I don't know if you would agree with that.
I think you're right, and I guess the challenge is now, so the psychological stress we're seeing in patients with chronic lung disease is around the lockdown and this sort of lack of social isolation. So it's a real swings and roundabouts for people in terms of they've perhaps not had many exacerbations, but there have been other consequences. And I think for people that have had COVID, it's that are struggling, it's around the ITU stays or the traumas of being in hospital and being alone. And yet we have other people who have had protracted stays on ITU, and Radio 4 came up to do some interviews, and so this gentleman was ready to talk, and I think they thought they were going to get this real, pouring out of emotion from this gentleman, and they said, so how's it being from a psychological point of view? He said, oh, fine. So we can't predict anything really with this disease. And of course, everybody responds to stresses differently, as you would absolutely expect. So some people have been profoundly affected, and other people have a more physical impact of the disease, which makes it challenging around a single rehab intervention to get it right for everybody.
And I think you've raised something. You put up on that complex sort of organogram, as it were, of the process, that it was very important to involve lots of different specialisms, and how easy is it in reality to signpost an individual patient to get the speech and language they require or the psychological support they require?
I think it's really hard, and whilst rehab is a very collaborative interdisciplinary intervention, it isn't to that extent on the whole.
Yeah.
And I think one of the keys is, and we've had a lot of discussion around this, is identifying the trigger questions that would provoke a referral. So we're saying to these healthcare professionals, we need your killer question, as it were, that would mean I need to refer somebody to a speech and language therapist, because I suspect in all the years I've been doing rehab, probably incorrectly, I haven't referred anybody for speech and language therapy. So I need to know from those specialists what type of patient they would expect to see, what's normal, and how we differentiate those patients. So there's been some really fascinating discussions, and I think it's, so anecdotally we spoke to the speech and language therapist, and they said, well, yes, we've got these 5 questionnaires we'd like you to use around voice, swallowing, taste and smelling. Saying, well, I'm really sorry, but that's not going to work. So it's been fascinating developing the assessment process for the COVID patients, so that we acknowledge all the symptoms in a concise way.
A very complex and difficult situation to work through. And have you felt that your service has missed some skills? For example, like some of the patients, if they've had a critical care episode, have you wished that they had actually gone into because there's a lot of debate about this nationally, a post ICU rehab forum rather than a pulmonary rehab forum, or has the service actually been able to support the patient, and in terms of also their potentially important physiological assessments to make sure of minimizing harm?
Yeah, I think that's an interesting question, and we've worked very closely with the physio department in Leicester, who worked on ITU. So we developed a system very quickly where patients would flow through, and we would take measures at the point of discharge and have a single piece of paperwork, if you like. So we weren't all assessing the same patient 60 times. So we've worked very closely with as many people as we can, but I think there's absolutely gaps. I think the other advantage we have in Leicester is that we work very closely with the cardiac rehab teams. So in terms of some of the cardiac abnormalities, they are of course much more familiar with that. So within our COVID programs, it's a collaboration between the cardiac rehab staff and the pulmonary rehab staff.
And I can see that for those people running pulmonary rehab in the community, that it's not going to be such a smooth transition. The patient is going to have to be sort of handed over from one establishment to another one rather carefully. Yeah,
I think that's, there's been a few interesting reports about cardiac involvement in post-COVID population, and of course that is of concern.
Yes.
Particularly if they've been community managed, but some of the reports around the post-hospitalised patients in terms of myocarditis and arrhythmias is of concern.
And if you were advising community teams on their assessment, obviously saturation and the absolute desaturation, but the rhythm of the patient's desaturation pattern and their cardiac rhythm is obviously very important. Do you have any words of wisdom that you would pass over?
So we've been discussing this at work with the cardiac rehab team who are far more versed in this than I am. But of course, we have all of that for patients that have been through the hospital. And for community referrals, we're now asking for an ECG.
Are you?
Yeah.
Okay, right. That's interesting.
How well that works, we don't know yet. But I think we're sufficiently anxious enough about some of the reported symptoms that we would feel more comfortable. And then, of course, if patients are reporting palpitations, and or chest pain, then we, would treat that appropriately, as you would through any cardiac rehab program if you still had concerns.
Yes.
Really ignore those sorts of symptoms.
And another question that I know is on a lot of clinicians' lips, and you mentioned in your slides that you treat the post-COVID patients very much like any other chronic lung disease patient, taking all the precautions in terms of the transmission. So is it business as usual for either group in terms of the PPE you might wear, the cleaning and all that kind of thing, and checking the patients on arrival?
Yeah, so it's exactly the same process for all the programs that we run, pulmonary, cardiac, and of course the COVID. So the requirements in terms of PPE, infection control, social distancing processes are identical.
Okay, thanks, Sally.